very warm welcome to this special presentation on CNN News 18, Live Long and Live Better with a Healthy Heart. Never in our lives did we look at our well-being and health so closely as we did in the pandemic times. We are faced with the reality that our health indeed is compromised. And now we need to give it all the protection we can, especially our heart. As it is, coronary artery disease affects approximately 2.1% of the population worldwide. And due to its chronic clinical manifestations and progressive disease course, it is a major cause of premature deaths and disabilities. Post-COVID complications include heart conditions as well. But what is also evidently clear, latest innovations and technologies are redefining cardiac procedures, and a diagnosis most certainly does not mean a complication, but perhaps an opportunity for timely intervention. And today we have the pleasure of learning from the global heart experts present here exactly what these new technologies are and how they are treating a lot of complex heart disease patients with absolute ease. We have with us Padma Shri Padma Bhushan Dr. Ashok Seth, Chairman of Fortis Escorts Heart Institute, New Delhi, and Fortis Healthcare Medical Council. Dr. Samin Sharma, Senior Vice President, Operations and Quality and Director of Interventional Cardiology at Mount Sinai Hospital, New York. He's also the President of the Mount Sinai Heart Network. Dr. Ronnie Matthew, Head of the Department and Senior Consultant Cardiology, Lizzie Hospital, Ernakulam. He's one of the most respected interventional cardiologists in South India and a pioneer of the imaging technology, OCT. Welcome, doctors. Dr. Seth, I'll start with you. India is considered as the diabetes capital of the world, and in most of the patients with heart disease, diabetes is prevalent. So are you seeing more complex heart disease patients nowadays in your practice? And how are you looking at the latest technology in treating these complexities?
So there's no doubt that the complexity of patients has increased over the last 10 to 15 years, and that's happened across the world. But more so, because we are the world capital of diabetes. Diabetes gives rise to multiple blockages, complex blockages, and so does increasing age, renal failure, patients who've had blockages for a long period of time, patients who've had previous bypass surgery and failed grafts. All these are very complex patients with extremely complex blockages. So clearly, we're dealing with more complexities as we do angioplasties to treat these blockages. But at the same time, thankfully, new technologies, new techniques have actually made angioplasty even safer and effective for these even very complicated patients. For example, I must tell you that diabetics and renal failure patients have heavily calcified arteries, and their blockages are such that calcium gets deposited and the arteries become very hard, and sometimes we are unable to open them up by angioplasty. But now we have extremely great devices and tools where we can actually scrape off that calcium within the arteries by a device, a drill called rotablator. And more recently, we also have miniaturized ultrasonic devices which we put inside the arteries, and almost like a lithotripsy for the kidney stone, these balloons from inside the artery fracture the heart blockages and help us to implant stents. Now, as we move into a patient to treat him, what's actually happened is that we have got special wires, which we put down the arteries, where we can measure the flow into the arteries, decide which blockages are severe, which are not severe, the ones which should be treated by a stent implantation and angioplasty, and therefore will do well in preventing heart attacks for the future, or those who should be left behind, a technique called FFR, or fractional flow reserve. It helps us to not do unnecessary stenting, but to give the right blockage, the stent or angioplasty, to improve outcomes and avoid unnecessary stenting. This triad of making sure which blockages require a stent and which do not require a stent by FFR, putting in the right and the most advanced medicated stent into the heart arteries, as well as assessing the results with optical coherence tomography, or OCT as we call it, is now the era of precision angioplasty, being very precise to give the patient the best outcomes. And actually, more and more centers and more interventional cardiologists are taking on precision angioplasty to give the best results to their patients in this era of heavily complex disease that we treat every day.
Dr. Sharma, as Dr. Seth said, we understand now that fractional flow reserve makes it possible to understand whether stent is required or not. You're one of the leading interventional cardiologists in the US. What has your experience been using this technology?
Once you are having a heart attack, an artery is completely blocked or 95% blocked, it's perfectly fine, go and do the stent. But if it is less than that, 60%, 70%, 80%, many times it is very much individual variation. Somebody reads that as a 60%, someone reads as 80%. Should this blockage be treated by stent? The key is, and that's where this FFR comes in. It stands for fractional flow reserve. And what it means is we give a medicine to increase the blood flow across the blockage and a computer readout. So it's nobody can manipulate, computer readout. And if it is less than 0.8, 0.8, that means the blockage is significant and can give rise to problem in the future, and therefore should be stented. If it is more than 0.8, then it can be left alone, and they do very well on medical therapy. The question came one time that what if it is less than 0.8 and we treat these patients with a good medication? What will happen? So there was a trial done called FAME2. The trial has to be stopped in 6 months. What they did is, in half of the patients, they put a stent when FFR was less than 0.8, and other half, they just continue medical therapy.
Dr. Seth, is the penetration of FFR technology low in India?
It is true that penetration of FFR is low at the moment in India, but is increasing every day because of the realization of its importance for the patient himself. Part of the reason that we not got a rapid increase, as you see in the United States, is here that the reimbursements have to come in more and more for the patient himself. Regulatory authorities, not just regulatory authorities, but payers have to realize the importance of these in decision making and in appropriate decision making, which affects patient outcomes. And therefore, the patient has to realize this, the payer has to realize this, and as you know, many a times it's the patient himself who pays for his whole angioplasty rather than third-party payers in the United States. And therefore, this form of education of realization that a technique like FFR can make a vital difference for the patient, for his well-being and outcomes, because it becomes important not just for the doctor. The doctors can understand it. They want to use more and more of it, but it becomes important for the patient to understand this and also for the payers to understand this.
Dr. Matthew, would you say the same? Is the penetration of FFR technology low in South India as well? And what has your experience been with the complexities that are coming with cardiac patients?
I think the penetration of fractional flow reserve at present is low than what we would like. But all large hospitals are doing FFR because that's appropriate. The smaller hospitals are catching up. But I think there's a steady increase in the number of hospitals that actually perform a fractional flow reserve because it's the right thing to do. The problem in India has been twofold. One has been the cost involved, because reimbursements do not come easily. And second is, we truly don't have guidelines specific for India that says that an FFR should be done. I think over a period of time, we would see the penetration increasing, and it is at present increasing.
Given your experience, Dr. Sharma, what are the suggestions to enhance the uptake?
At present, we have American Society of Cardiology, ACC, American College of Cardiology, and we call NCDR, which is the National Registry. Then same thing in the European Society of Cardiology. All those committees, guidelines are coming that FFR gets the top priority, which we call class 1 indication. That once you're doing a PCI in a patient who is not having a heart attack, that FFR gives you the best outcome. So it is level 1 indication. So it means most appropriate. So once this really come into everyone's life, anything you come up with the guidelines, rules, regulations for that matter, it takes about 4 to 5 years to really adopt it. And I think we are in that phase now. in India. And I'm not surprised that in the next 2 years, the number of FFR use will be just about what is in United States. Like every 2 out of 3 PCIs will be done using FFR, because it has the highest level of evidence, because just not looking at the angiogram only, but adding to the angiogram that which blockage can give trouble or which can be just managed medically. Only one tool we have at present by multiple trials to support the data that do it or not do it, stenting in those blockages which are between 50 to 80% in on angiogram.
Dr. Sharma, we spoke about percutaneous coronary intervention, PCI. What exactly does it mean? Also, when choosing a drug-eluting stent DES for your patients, what are the qualities and criteria you usually look for?
The PCI basically stands for percutaneous coronary intervention. Means you're opening the blockage without surgery. One, when you have a significant blockage, either when medication fails, either you do a stent, which is the PCI, percutaneous coronary intervention, or you do a patient go for bypass surgery. So PCI require stenting. Even if there is a calcific blockage, we take care by the rotablation or by shock wave technique, but still stent is ultimately placed, because stent is the one which has shown to give a great results. So key is that of the various DES available, there are 6 now in United States. 2 were added just last year. Before that used to be only 4. And in India, we have multiple, close over 40 DES available. So what is the advantage of an FDA approved stent? That basically means that it has gone through very strong scrutiny, showing the results short-term as well as long-term benefit. So FDA gets a special label, same thing for any brand name you use. So clearly, once you have a special brand name, it gives the additional comfort for anybody. So same thing is for the DES. So FDA approved stent, in my opinion, to a interventional cardiologist before making a decision which stent to use, FDA approval gives the extra stamp of safety and efficacy on a long run. So I always advise, as much as possible, use FDA approved stent even in India.
Well, thank you for that insight, doctor. Time now for a very short break. But when we come back, we talk about optical coherence tomography, OCT. You're watching Live Long, Live Better with a Healthy Heart. Welcome back to this special presentation on CNN News 18, Live Long and Live Better with a Healthy Heart. Taking the discussion forward, Dr. Matthew, in precision angioplasty and stenting, what is the role of OCT? How best to explain it first?
You see, for the last 50 years or so, treatment of heart attacks and chest pain has been guided by an angiogram. An angiogram is basically a 2-dimensional X-ray image of the blood vessel. Now, with this new imaging technology, that's an optical coherence tomography or OCT, this has been a game changer, because with this technology, now we have the ability to see inside the heart vessels, which we call the coronary artery. This is important because it's the blockage in this vessel that causes a heart attack. So to put it in simple terms, it's like sending a video camera into the coronary artery and seeing it from the inside. With this, we of course have a better visualization of the blocks that cause a heart attack and the disease process itself. Now, the ability to visualize the exact disease process is important, because as Dr. Seth and Dr. Sharma said, the blocks that cause a heart attack have different compositions. It may be soft, as with the cholesterol deposit, or it may be a hard block with a calcium deposit, like the hard bone we have. So once we understand what these blocks are made of, we can plan the exact modality of treatment.
You were the principal investigator for the first Indian clinical trial on benefit of imaging in stenting procedures, Dr. Matthew. What was your experience like?
We are very excited with this research study, the iOptico, or the Indian Optico study. This is basically done to demonstrate or verify if the imaging that we are talking about, that's the optical coherence tomography, had an impact while performing an angioplasty with a stent. And this was conducted at 9 large cardiac centers in India. Now, the results were very fascinating. It showed that when we see the coronary artery from the inside with an optical coherence tomography during the angiogram, we are able to analyze the disease and hence change our decision on how to implant a stent in about 70% of patients compared to when we only use an angiogram. Similarly, after the stent is implanted, OCT imaging can detect imperfections or defects in our procedure in about 30% of patients, which we then correct and prevent a complication from occurring. So, 𝐆𝐫𝐞𝐞𝐭𝐢𝐧𝐠𝐬 study proved that imaging with OCT helps us do a better job, helps us perfect our stenting, and do what we call now as a precision stenting. We were very happy that this paper and its findings were appreciated worldwide. This, I truly believe, is progress in the treatment of heart disease because it enables us to treat the patient better and helps us live longer.
Dr. Seth, in this pandemic, when both the patients and HCPs are at risk of COVID infection, do you suggest that precision PCI perhaps is the best way forward?
I'm glad you asked about COVID because the last 2 years have been truly a game changer, an eye-opener for many of us. During the COVID times, we had many young patients come in with heart attacks because, as you realize, COVID precipitates clotting in the arteries of the heart. It also exacerbates previous existing heart disease for many of our patients who are elderly. And therefore, clearly, after the initial lull, we started realizing that these patients needed even better treatment. And because that these patients get more clotting, our angioplasties had to be perfect on these patients. The stent implantation had to be meticulous. Our results had to be so good that clotting would not happen on the stent. After all, a stent is a foreign body. And when we insert into the arteries of the heart, unless we have actually seen it, done a very good job, and made sure that the stent is expanded completely and fully, we may actually get a clot on that forming, which leading to blockage of the artery and a heart attack. And therefore, it became so important to give them precision stenting. So finally, if I had to sum up, not just our approach to the COVID patients, but our approach to every patient who develops blockages in the arteries of the heart, who needs a good result, and for whom we are responsible for giving the best outcomes. After all, I always say that do to your patient what you would have to yourself. And this triad of precision PCI or precision angioplasty, as we call it, actually makes our patient live better and clearly live longer.
Dr. Sharma, your closing comments.
This current tools of various techniques which we have described today, what has done is has elevated the success, not only short term, means very low complication, very rarely patient go for emergency bypass surgery, but also as a permanent long-term relief, long-term benefit, just like patient have after having a bypass surgery. So that is where this all combination which to improve our outcome of stenting we have discussed today. So, and that is why the India actually, the PCI numbers have increased. In America, we do about 10 lakh PCIs per year. India does about 5 lakh, which is second highest in the world. And Japan used to be about 4 lakh. India has surpassed in last 1 or 2 years, just because it is very, very effective and safe technique. So no longer that you are getting stent now and you'll get a bypass after 5 years. No longer true. Many conditions, stent, even multiple blockages is a final cure. It, of course, they have some chance of reblockage, but it is not that every stent patient after a few years going to go for bypass surgery. Now what we are talking with various these tools, optimize, make our stent results better, perfect, with the long-term benefit for the patient and the society.
Well, on that note, it's a wrap on this special presentation. Thank you, doctors, for giving us your precious time and explaining so patiently how these new technologies of FFR and OCT are supporting the physicians to perform the PCI procedure accurately and helping the patients to have an excellent clinical outcome. Thank you all for watching. Live long and live better with a healthy heart.